Great. I hope people are going to be coming in from the previous session. It looks like people have started to do so. With this next session, we're going to shift gears and take a strong focus on COVID, health literacy and COVID. Really, one of the international leaders for this arena of work has been Mike Wolf and his team, and connections that they've made to accelerate research in this area in various places around the world. And with that, I'm going to hand it over to Mike. If you will turn your video on, we can see where you are there in Chicago with a boy band behind you. I'm going to be lurking around, managing some of the chat questions that come in, and I'll come back in towards the end for the Q&A. But take it away, Mike.
Great, thank you, Michael, as always, and greatly appreciate HARC weathering the COVID pandemic and staying alive. And so I'm going to quickly share my screen here, and I believe I hope this is the correct view. Are you seeing just the slide, Michael?
Actually, we see the slide and your next slide.
Got it. There we go. So I'm just going to quickly serve as kind of an introduction to three other speakers that I'm very excited to have along with me in this panel to talk about some of the work around the psychosocial impact of COVID, including health literacy in the kind of the topic of what we're all experiencing right now. I'm going to just give you a quick overview of some of the work that we've had the fortunate ability to work at Northwestern and with our collaborators. And so I'll just introduce what we're calling our C3 study briefly, and really leave it to Lauren Absasnik at the University of Michigan to share some of the findings that we've had been able to kind of deal with related to health literacy and its impact on experiences during COVID. And then also Dr. Marina Serper, who is going to be presenting some of her work with us that has really reflected COVID-19 and telehealth and any barriers that we around health literacy and limited English proficiency. So really great work that she led on that regard. And I want to introduce you to a wonderful new colleague. One of the nice benefits with Zoom and all of us, kind of working remotely these days is being to make the ability to meet some new collaborators internationally. And Dr. Nielsen is in Denmark and has been leading a national effort there on understanding the impact of COVID-19 on individuals with chronic conditions. And we found a lot of similar parallels to our work, and we've been able to correspond and connect and in some ways, if possible, even kind of align our research interests. So I'm really excited Dr. Nielsen could join us today and share some of her work and perspectives as an international collaborator. So the title, The End is the Beginning, looking at spillover effects. And again, the work that we've been doing at Northwestern is really focused around those with multiple chronic conditions, people who really needed healthcare at a time where how they accessed it was changing. Some quick disclosures. And yes, it's another COVID story. So I'm assuming that maybe those of you who are on this presentation are still interested in it, even though I think we're all getting a bit of COVID fatigue in terms of our research, and would like to just in some ways just return to what we were studying before. So did want to tell you a little bit about our COVID stories. Again, Lauren and Marina will present our work in the US. A lot of our focus has been on what we call a pre-peri post-trauma investigation with what we are doing with C3. And give you a little bit of background. I'm going to let Lauren talk about the methods, and Marina and Laura will share initial findings and some of the studies that are also in progress. But just in general, the C3 study is something that we launched at the very, very beginning of the pandemic, in the first week, at least, of the outbreak in Chicago. And again, Lauren will share some stark numbers so you can really get a sense of how our survey has been collecting data and what was the exact experiences we were living with that are kind of hard for us to remember now, us being 19, 20 months into this pandemic. We started off as a study called the Chicago COVID-19 and Comorbidities Project, which really was leveraging existing cohort studies that we already had funded through NIH where this was a well-characterized sample before COVID, and then thinking about tracking those individuals throughout their experience so we could see trajectories of patient-reported outcomes and also healthcare access and clinical outcomes, given that we had access to the entire cohort with electronic health records. So again, it has now been funded. We did 3 waves of surveys as a longitudinal study, and it's now been funded by the NIA. And we're looking to actually, right now we're waiting on additional funding to come through. So we'll be actually capturing a full 5-year window of time post the initial outbreak of COVID. We have then changed the name to C3 COVID-19 and chronic conditions because we've also done outreach. So we've got collaborators in the US who are also using our survey at Mount Sinai in New York, as well as in Louisiana State with our colleagues Alex Fetterman and Terry Davis. So we kind of view this as a larger kind of bucket, more in the C3 kind of avenue. So real quick, before I turn it over to Lauren, taking a flashback in time, again, I think time has kind of lost a little bit of its sense to me these days, but really thinking back to March 4th, 2020. Just in Chicago locally, this was the news that was dominating, the storylines, not COVID at all. COVID was kind of very limited, and it really wasn't making much of an impression in terms of cases in Illinois or deaths in the same regard in the US. In fact, pulling from the Washington Post, this was the main headline from March 4th, Jill Biden protecting President Biden from lunging vegans. The CDC guidance really was, we weren't really fully capturing where we're at. And the reason I pitched this, just to present where we were in context back in early March, this is where we were at when we launched the first of the C3 studies. Clearly things are much, much different now. And so from that end of it, I think it does behoove us to kind of just realize how much has happened and how these perspectives have changed when we look at our data. Just real quick, and then I'm going to turn it over to Lauren. The research questions that we thought we were uniquely kind of in a position to study, because we had this natural cohort, well characterized and all, that we could kind of leverage quickly and pivot again rapidly to collect a very quick cohort, because we needed to do it basically in 6 days, as you'll see with Lauren's slides. Because otherwise the changing attitudes, and what we were learning was, as you remember, was just on the fly, and we really wanted to get the cohort quickly so we could then move and continue to study this group over time. It's comparable to what other groups like Kaiser and even like Harvard, I believe, have done, which are more cross-sectional in nature. This was meant to be longitudinal. So we're looking at how middle-aged and older adults with underlying health conditions at higher risk for adverse outcomes from COVID were responding to the pandemic, and what are the consequences of COVID-19 on individuals' health status, their ability to prevent infection and spread, and again, continue to manage the care and receive the care that they need for their underlying conditions. So with that, I'm going to turn it over to Lauren, and very excited to be here, and thank you for participating. But Lauren, why don't you take it from here?
Yes, hello everyone. Thank you so much for having me, and thank you, Mike, for the introduction. So I'm going to share my screen. Okay, I think, can everyone see that all right? Great. Okay, so a little bit about myself. My name is Lauren Obsasnik. I am a statistician on Dr. Wolf's group at Northwestern University. And additionally, I am studying to get my PhD from the University of Michigan School of Public Health in the Department of Epidemiology, specifically focused on chronic disease epidemiology. So I was fortunate enough to be one of the main analysts on this C3 study. And so I'm going to present today a little bit about the methods and results that we found from our first few waves of data collection. Okay, so as Mike had said, once we kind of realized that COVID was in the news, it was kind of here to stay. Governor Pritzker in Illinois had enforced a stay-at-home order. That's kind of when we realized there were potential implications on the older adult population, which much of our research focuses on. And so our research team quickly pivoted to start observing the possible effects of COVID-19 on our research participants. So we developed the C3 study in order to do this. And the C3 study is a telephone-based cohort study that currently has 6 waves of data collection completed, ranging from March of 2020 to August 2021. And right now we are actually in our 7th wave of data collection. We're about a month and a half in.
Hello.
So we have our C3 study is comprised of 5 parent studies that all have some degree of uniform data collection as well as EHR data access. So all participants that were recruited into our study had 1 or more underlying health conditions, and they were recruited from 5 academic medical centers and 2 federally qualified health centers within the Chicago area. And finally, all of our study participants had allowed us to contact them for research purposes following their parent study interview. So here is a table with our 5 NIH-funded parent studies. And I've included here their study design and their eligibility criteria as well. So as you can see, the 3rd study down, we actually do have a mix of English and Spanish participants. And we did include the Spanish-speaking participants in the C3 study. So it does add a bit of uniqueness to our study as well, and a bit of diversity. And so during wave 1, which was the initial outbreak period, we really put together this brief survey in order to capture some main objectives, main points. And we were really interested in looking at the initial COVID-19 awareness and concerns, general knowledge that our participants had on COVID-19, including symptoms and methods of prevention, and then any related behaviors and preparedness that they'd felt at the very onset of this pandemic. So here's a snapshot of some of the measures that we've included in our initial survey, and we've continued to capture a lot of this information in subsequent waves as well. So we asked them things like, how worried are you about contracting the coronavirus? Have any of your routines or behaviors changed during the pandemic? And how prepared were you for the COVID outbreak, among others as well? So back in the spring of 2020, we did have our wave 1 results published in the Annals of Internal Medicine. And this was primarily dealing with the awareness, attitudes, and actions related to COVID-19 among the chronically ill participants. So for the first wave, we had 1 week of planned enrollment where it was between March 13th and March 20th, a very specific targeted time. So our research team targeted patients who had a most recent interview in their parent study, which was around 1,300 participants. In all, our team contacted 783, and in that week period, 673 adults were recruited to the study with a response rate of 86%. And like I said previously, we do have a fairly diverse cohort comprised of mostly older adults, where 1/3 of the participants are Black, 1/5 are Latinx, and 11% are low English proficiency. We also have about 1/3 of our sample is living below the poverty level. 2/3 are living with 3+ chronic conditions, and almost half of our sample is limited health literate. So here are some of the most interesting results that we kind of found from our wave 1 study. So at the very onset, so again, from March 13th to March 20th, about 1 in 4 participants reported being very worried about COVID-19 at the onset of the pandemic. About 1/3 of the participants were not able to identify either 3 symptoms or 3 possible ways of preventing infection or spread of COVID-19. 1 in 10 felt that they definitely or probably likely would become infected with COVID-19. And then 1 in 5, even during this time where there were a ton of stay-at-home orders in place and a lot of hype in the media during that week period, 1 in 5 reported that they had COVID had little or no impact on their daily routine, and they weren't changing any plans that they made in response to the pandemic. And 1 in 5, only 1 in 5, felt very prepared for the COVID-19 widespread outbreak. And this was a result that was very shocking to me because the government was supposed to be leading the charge in this, but only 1 in 10 were very confident in the federal government's response to the COVID-19 outbreak. So looking at the multivariate results, in the first week of the pandemic, individuals who had low health literacy were more likely to believe that they weren't going to be sick from the pandemic, that the threat was no different than the common yearly flu, and they did have more confidence in the federal government's response. Yet these were the same individuals who were not feeling prepared for the pandemic. So there was definitely a very clear disconnect at the start of the pandemic, whether it be messaging or things like that. But we did find some very interesting results in that regard. So this is a really interesting graphic to me because it shows the COVID cases and total deaths in both Illinois and in the US as they align with our waves of data collection. So as you can see, the interviews did align with some of the major COVID peaks that we experienced, particularly looking at wave 5, when there was that large surge around the end of 2020, beginning of 2021. So this allowed us to capture some really crucial information during these time periods, and even during the kind of valleys where there were some lulls in COVID, we were able to assess people's reactions during both time points. So for a bit of a larger picture, here's a study. Here is some of the measures and outcomes that we've collected both pre-COVID as well as for the C3 cohort and our proposed RO1 that will hopefully allow us to collect data on our participants for a full 5 years. So we're trying to get information on everything from participants' COVID beliefs and actions, including their vaccination status, their testing and diagnostics, as well as any changes in behavior they may have experienced, like harmful alcohol use, smoking, physical activity. And something to point out that has been a big piece of our research that a fellow on our team, Dr. Rebecca Lovett, has kind of taken on, has focused on the toll and the continued toll that COVID has on our patients' physical and particularly mental health, looking at anxiety and depression over time. So finally, we've really, because the pandemic unfortunately has been going on for 1+ years at this point, we've started to take a look at some of the trajectory data. And I personally was very interested in looking at individuals' perceived susceptibility to COVID-19 across our waves of data collection. So I was able to, when I was looking at this susceptibility, I found that C3 participants who perceived COVID-19 to be less serious, so saying that it was no worse than the flu, and they weren't taking actions during the initial waves of data collection to protect their health, were 2 times more likely to get COVID-19 over the subsequent 12-month period. And 1 in 5 participants have sustained a consistent belief that they're not at all likely to be infected with COVID-19. And disparities in this analysis do exist by race, ethnicity, health literacy, and employment status, as well as others. So this was just a brief overview of our findings, particularly from wave 1 and some trajectory. But I believe Marina Serper will be talking next about the telehealth piece. So thank you very much for your time. I'm really excited to be here.
Great. I think actually we're going to go to Dr. Nielsen next, but Marina Dr. Serper will be following up with more from the C3 study. But if it's possible, if Bree, you want to join us? They're great. As a quick introduction, Dr. Nielsen is an academic psychologist and senior researcher, and she's working right now on in the field of patient and public involvement at De Factum, which is a social and health services and labor market company focused on the central Denmark region. And a lot of her research focuses on patients' motivation, opportunities for and resources for involvement in their health and healthcare, as well as healthcare professional experiences of and reasoning about patient involvement methods and interventions in healthcare, and the capacity and sustainability of the healthcare system to involve patients. So I'll turn it over to you, Bree.
Thank you, Michael. And good afternoon from Denmark. It's getting dark here, so I guess you'll be having lunch soon. I will just share my screen. So can you see my presentation?
Yep.
Yeah, that's good. So first of all, thank you, Michael, for giving me the opportunity to present some of the findings from the Danish PAM COVID-19 study. It's a pleasure to be here today, and I'm going to give a talk about the impact of COVID-19 on mental well-being among Danish adults with pre-existing chronic condition and its associations with patient activation. As Michael said, my name is Berit Kjærsted Nielsen, and I'm a senior researcher in Central Denmark region and Aarhus University in Denmark. So I don't think I'm able to shift it here. Yeah, so good. Just to give you, if some of you don't know, Denmark is placed in the Northern Europe and have a population of nearly 6 million. And just to give a short overview of the Danish healthcare system, the basic principle is that all citizens have equal rights to social security. And a principle is that all citizens are available, the number of services available to citizens are free of charge. The Danish healthcare system is universal and based on the principles of free and equal access to healthcare for all citizens. And the healthcare system offers high quality services, the majority of which are financed by general taxes. And on September 10 of this year, Danish authorities lifted all pandemic restrictions in our country and pronounced that COVID-19 is no longer a critical threat. And as you can see, my son was out yesterday for Halloween, and it was just wonderful to see the kids walking around somewhat carefree. Vaccination rates are high in Denmark. 86% of all eligible citizens 12 and older have received at least one shot, and 95% of people 50 and older are fully vaccinated. In relation to health literacy, which is the agenda for this conference, a population-based study in Central Denmark region from 2017 found that people with long-term conditions reported more difficulties than the general population in understanding health information and actively engaging with healthcare providers. And as many of you know, probably much more thoroughly than I do, health literacy is a concept that encompasses how patients understand health information that they receive and how they use it to make decisions in the healthcare context. Whereas patient activation refers to the level of knowledge, confidence, and an ability to commit to health self-management. Studies indicate that health literacy and patient activation are separate concepts that are only moderately correlated with each other. And studies also indicate that patient activation and health literacy can each make independent contributions to outcomes. So Denmark's death toll during the pandemic was low, only 450 people per million citizens compared to 2,000 per million in the United States. Denmark, however, as the rest of the world, in the beginning of March 2020, Denmark followed closely the development of coronavirus, and especially the situation in Italy was closely covered by the Danish media and brought fear and worry to many Danes. And as the graph illustrates, we launched the PAM COVID-19 survey when there were only few cases of the virus in Denmark, and we followed up with a second survey to participants from survey 1 who consented to receive a second questionnaire 6 months later. And that turned out to be when the numbers were beginning to rapidly increase. So the aim of the present study was to investigate the impacts of COVID-19 lockdown on mental well-being among Danish adults with chronic conditions during the pandemic. and to investigate the association between perceived patient activation, COVID-19 awareness and worry, as well as mental well-being. Participants from 10 municipality health services were screened for eligibility on 2 criteria. Adults over 18 years of age with 1 or more chronic conditions who within the last 12 months from March 2019 to March 2020 had participated in a municipal health course and had completed the patient activation measure within the past 12 months and prior to the COVID-19 outbreak. And that consisted as a baseline in this study. So the pre-COVID data were on eligible participants were extracted from the Danish MOEVA database. And just in short, MOEVA is a monitoring and evaluation database used to collect patient-reported outcome from patient education courses in municipalities and hospitals in Denmark. Pre-COVID measures consisted of socio-demographic and disease variables, so we didn't have to collect them again, as well as the patient activation measure. PAM measures a person's knowledge, skill, and competence to engage in the process of one's care and self-management. Besides the total score ranging from 0 to 100, you can calculate 4 levels of activation. In the lowest level, you feel disengaged and overwhelmed. In level 2, you are becoming aware but still struggling. In level 3, you are beginning to take action. And in the highest level 4, you are able to maintain behaviors but may not necessarily sustain them under stress. So COVID-19 awareness and worry items were adapted from ongoing national and international studies, including the C3 survey led by Professor Michael Wolf. These included questions about perceived difficulties in finding and understanding information on COVID-19 and whether they believed their own everyday action had a saying in getting COVID-19. Single items also included worry items containing feeling stressed, having trouble sleeping, and feeling lonely. So a total of 1,273 participants returned the May 2020 questionnaire, whereas 710 participated in both surveys, giving us a response rate of 56% in the present study. Results from the first survey is published in Danish only, as we were eager to get the results back to the municipalities, health organizations, and politicians back then. Okay, so the sample in the present study consisted of 710 Danish adults with a mean age of 61, and of which over half were female. The majority lived with another person, and nearly half of the participants had a medium level of education. More than 40% were living with 2 or more chronic conditions, and finally more than 2/3 had low levels of patient activation. Most prevalent chronic conditions were type 2 diabetes, cardiovascular disease, chronic obstructive pulmonary disease, overweight, and cancer. Non-response and dropout analysis showed that participants were more likely to be of younger age, have higher educational level, and have slightly higher patient activation than non-responders and those who said no to receiving a second questionnaire. So looking at the results from the beginning of the pandemic, more than half of the participants considered themselves to be at increased risk of becoming seriously ill if they were infected with COVID-19. The vast majority agree or strongly agree that their own actions have an impact on whether they are infected with COVID-19. More than a third say it has become more difficult to take care of their own health during the corona crisis, and 16% answer that they have had health problems that they have not contacted a doctor or other healthcare professionals about due to the corona crisis. Finally, more than half of the participants feared that they will not live their lives again as before the corona crisis. Taking the results and looking at the PAM level, more people with lower levels of patient activation, level 1 and 2, indicate it has become more difficult to take care of their own health during the corona crisis. The mean WHO-5 score measuring well-being for participants was 65.8 for the total sample in May 2020, which was around the same level measured in the general population in a Danish cohort in the same period of time. However, looking at the mean values among participants with different levels of patient activation, we found that having lower levels of patient activation was associated with lower well-being compared to those with higher levels of patient activation. And the differences were statistically significant. And finally, we found a significant decrease in well-being in the total sample from May to November 2020. A multivariate variate linear regression was performed to examine the effect of socio-demographic and disease variables, as well as COVID-19 related concerns, well-being measured in May 20, and PAM score on well-being measured in November 2020. The results showed that although well-being measured 6 months earlier was the strongest predictor, patient activation was statistically significant associated with well-being in November 2020. So results from the PAM COVID-19 study show that a significant proportion of people with one or more chronic conditions have been mentally burdened as a result of the COVID-19 lockdown in Denmark. Patient activation level plays a significant role in the ability to maintain function and health during a major disruption in daily life. Well-being among the participants decreases from May 2020 to November 2020, and people with lower levels of patient activation seem to be more affected. Many of the studies that were initiated in the beginning of the COVID-19 pandemic consisted of online surveys using non-probability and convenience samples. And in order to understand prevalence in a population, it is important to know who the responders are, as well as who are the non-respondents. A strength to our study was that we were able to identify eligible participants from the MOEVA database consisting of individual level register data, and therefore could perform non-response analysis and report potential non-response bias. And as I stated earlier, compared to non-responders, the study cohort was actually older and had higher levels of patient activation and higher educational level. So one would assume that having more non-responders in would even strengthen the results. However, our pre-COVID baseline measure on PAM was collected, as I said, within 12 months prior to the pandemic. So we don't know if participants' PAM has changed since they were last filled in, leaving us with some precautions regarding the results. The COVID-19 pandemic has shaken the world and shaken every one of us. And our study demonstrates that having higher levels of patient activation seem to empower people when they experience stressful life events. This highlights the importance of implementing self-management and community-based health services, but also to foster patient-reported outcome as a tool to identify people who may have greater need for self-management support. Moreover, people with long-term conditions have experienced reduced or missing health services alongside limited social support during the pandemic. This may have an impact on mental health, and increased mental health problems can complicate existing physical impairments. Therefore, there is a need to develop clear guidance for people with long-term conditions in order to ensure continued access to care and support in times of crisis. So I have not done this by myself. I have a lot of colleagues who have been so kind and so generous in using their time in the beginning of the pandemic to help me with statistics, help me getting the database ready, and I owe them a lot. And finally, also thank you to Michael and Professor Helle Terkelsen Meindal in Denmark for collaborating with me. Yeah, thank you.
Thank you very much. I love your logo. Wonderful.
Thank you.
So moving ahead, so there's time for questions. I get to introduce Dr. Marina Serper, who will round us out as our last presentation before going to questions. So maybe I can call up Dr. Serper. I will be sharing her screen, my screen, to advance her slides, because I know she's been having some technical issues logging into this Zoom. So let me go ahead and do that. And now go to there. Okay. Sorry there.
Okay. Hi, everyone, and thank you for having me. I'm audio only today because my internet has decided to block Zoom for some reason. So thank you so much to the organizers, and thank you, Michael. We're going to talk about health literacy and telehealth today. Next slide, please. So first we'll discuss a little bit about the pandemic and what it's done to telehealth, particularly in the United States. I will then share with you some data about health literacy and telehealth acceptability and uptake from the C3 study that you heard about from Lauren. And then I'm going to give you an example of what our health system at the University of Pennsylvania, which is a large tertiary care center, did to rapidly deploy telehealth health system-wide, and how we were able to utilize some health literacy best practices. And then we'll talk about some future directions. Next slide, please. Okay, next. So prior to the pandemic, telehealth in the United States.
Just a moment, Marlena. Sorry, Marina.
Yeah.
Hey, Mike, will you switch to presenting mode? You have two screens showing.
Oh, I thought I had it. Sorry about that.
Sorry, Marina.
Is that right?
No problem.
That's better. Thank you.
Thank you.
Okay. So prior to the pandemic, telehealth use had been increasing in the United States, but actually was quite hampered by lack of reimbursement by insurance, also the requirement for the patient to be in a healthcare setting rather than at home, as well as interstate licensure barriers. And so telehealth claims during early COVID, when these restrictions were lifted during the public health emergency, grew by 78 times and had since stabilized at about 38 times. So we had seen an explosion in telehealth services due to the loosening of these restrictions to enable access to care. Next slide. So this shows you data from the Kaiser Family Foundation about Medicare recipients, which covers older adults in the United States and those with some serious chronic conditions. And according to these data, 2/3 of Medicare beneficiaries reported that their usual provider offered telehealth services. This was up by 18% before COVID. Next, please. But as you can see, and this would probably not surprise you, patients who are Black and Hispanic, those who are older and live in rural settings, are less likely to have reliable access to the internet, to own a computer, and to own a smartphone. Next. And so next, I'm going to show you data from the C3 study. And actually, you heard a lot about the background of this study. So I'm going to go through the background and the cohort a bit fast and just really focus on the results. Next slide, please. So the objectives of the C3 study, as you heard from Lauren, which was deployed predominantly in Chicago, was to assess how middle-aged and older adults are responding to the COVID pandemic. How does this affect their health status, access to care, and ability to self-manage? And next, please. We also assessed what did these adults think about telehealth services, given the fact that we had a lot of robust health literacy and other data. Next slide. And so this again shows you an overview of the pre-existing cohorts that were interviewed as part of the C3 study. These were NIH-funded studies that were ongoing. Next slide. And so the C3 sample that I'm showing you is going to be a subsample of 673 adults that were recruited within the first week with an 86 response rate. Next, please. And as you can see, you heard about this in more detail from Lauren, but the C3 cohort has mostly older adults with a mean age of 62, 1/3 Black, 1 in 5 Latinx, and vary on literacy and other comorbidities. 1/3 of these adults are living below the poverty level, and half have limited lower marginal health literacy. Next, please. So the next slide shows you wave 5 data from the C3 cohort, which was obtained from December 2020 to March 2021. On average, in terms of telehealth use, participants reported 2 to 3 telehealth visits in the past 4 months. And there was no difference in the number of visits by patient literacy, age, limited English proficiency, race, ethnicity, or by self-reported health. Next slide. So in terms of the use and perceptions of telehealth, if you just click next, we did see some interesting differences by low and marginal health literacy in telehealth use and acceptability. So those with low and marginal health literacy compared to those with adequate literacy as measured by the newest vital sign were less likely to have a video visit, less likely to have a specialty care visit, more likely to have difficulty recalling what was discussed during the visit, less likely to recommend telehealth to someone else, and less likely to find telehealth very useful. Patients with limited English proficiency were half as likely to have a video visit, half as likely to think telehealth appointment was just as good as in person, and less likely to find telehealth very useful. Whereas those with poor self-reported health were twice as likely to have difficulty recalling what was discussed during the visit, which really highlights that there are significant differences in how patients access telehealth and how they can use it to understand their health and have a meaningful clinical appointment. And if you just click on the next slide, now that we have some of this background, I'm going to show you how our large health system at the University of Pennsylvania, which again is a large tertiary healthcare center, responded rapidly to the COVID pandemic, some of the lessons learned, and some of the best practices that we've been implementing. Next slide. So the challenge in our health system was that pre-pandemic, we delivered about less than 100 telehealth visits per day, mostly under small programs like telegenetics or neurology and under research conditions. Pre-pandemic solution required our providers to work from a dedicated health system telemedicine workstation with pre-existing software. And the workflow was kind of slow and really precluded adoption by other providers. You really needed to know how to use the software. And there were some missing key features in the software, such as translation and patient messaging. Next, please. So our challenge was to scale up telehealth use to meet the needs of our healthcare system that serves 6.7 million patients a day. And we needed to be able to offer at least 70% of our services virtually. Next. So here was our immediate health system response. So over the span of 1 weekend, we had to choose a different vendor because we immediately crashed our system using the old vendor. So we selected one of the vendors, which is called Blue Jeans, and activated this over the course of 1 weekend. We had a telemedicine command center, which was actually deployed by the volunteer services of our medical students who were sent home during the pandemic because they were not allowed to see patients at that time. And so they offered both patients and clinical practices tech support of this Blue Jeans platform. And then we developed our own in-house, what we call a wraparound telehealth platform. We call this a switchboard. This is a standalone platform that interfaces with our EHR and the Blue Jeans telehealth vendor to be able to see the patients, how they're scheduled, to be able to see in real time whether the visit is ongoing, and to be able to send patients emails and text messages through the switchboard to give them telehealth visit information in real time if it's needed. Next slide. This is just to show you that Penn Medicine had actually been building a telehealth ecosystem, if you will, that involved inpatient home care, long-term care, and outpatient care. We just weren't able to scale up the system sufficiently, again, due to reimbursement barriers and the fact that we didn't really need to use it. But we did not start telehealth from scratch. We actually had a pre-existing infrastructure. Next slide. So now I'm going to show you how the telehealth system works. So basically the way that we did this, we would, and you can go ahead, Michael, and just advance, yeah. We would send patients a message via email and via text at the time of scheduling. And you can go to the next slides. 3 days before the appointment, as well as 10 minutes before the appointment. And so what we're able to do is to send a patient a visit guide to have them be able to test out their video and audio connectivity. And also we send them a reminder 10 minutes before the visit. Now, this was not implemented right away. In the beginning, we actually sent them instructions to use the Blue Jeans vendor, and there was a requirement to have a login and a password to be able to download the app. And we noticed that this really created a lot of difficulty for patients. And so we decided to be able to deploy just a single click to patients via text or email was much easier, not requiring any sort of software download or any sort of username and password. Next slide. And we can go ahead and advance through some of these screenshots here. They're somewhat redundant, but this is kind of clear messaging that we give patients. The other thing that we developed, if you go to the next slide, is translation services. So we're actually able to translate, I think automatically now it's up to 63 languages or so. And so we are also able to enable third-party connections during the telehealth visit with the translators and with patient caregivers, which was not a functionality that we were able to have in the beginning, but this was something that we were able to build in response to patient feedback. Next slide. And so we early on also surveyed our busiest telehealth providers, and we got about 100 provider responses of what are some of the best practices for telehealth technology. And I'm not going to read all of these to you, but some of the key takeaway points were that really having a technology that doesn't require the patient to download an app, to have a technology that is not associated with a patient portal, again, because of the username password issues, patients may not be able to retrieve those on short notice. Enabling multi-party connections is really important, including translator services and family and caregivers who may be joining from another place, where a different place where the patient is located. And also we found that screen and image sharing was helpful to be able to teach patients. This was particularly for teledermatology, but also for some other specialties. And then there are a lot of other kind of pearls here that you can just take a look at. Next slide, please. Okay, let's go and look at our early patient experience. I'm a gastroenterologist, hepatologist, so I take care of gastrointestinal liver diseases. We deployed a survey through our patient portal and also by calling patients to see what were their early experiences with telehealth in our subspecialty clinic. And we looked at responses by age, sex, race, visit type, and whether or not patients were familiar with the portal or with the EHR portal or were already enrolled in the portal. Next slide. And so we interviewed 788 patients, and we saw that there was high satisfaction overall with visit quality and technology. This was within the first 4 weeks of the pandemic, so this was pretty impressive. We did find that younger patients and portal users were more likely to report that the visit was high quality, I think underscoring the fact that these patients have higher digital literacy, and Black patients less likely than white patients were less likely to report that the technology was easy to use. But overall, the satisfaction was high, and patients thought that the visit quality and the medicine delivered to them was high. And the next slide just shows you that we are still very active in our telehealth program. And there are some days that we have over 2,000 telehealth visits, even as we have been scaling back. And really, right now we have a hybrid model where 10 to 30% of our health system visits are via telehealth. But early in the pandemic, it was as high as 90% telehealth. Next slide. So in summary, COVID-19 catalyzed the telehealth expansion, facilitating access to care for patients. However, those with low health literacy, BIPOC, low English proficiency, those with older age and multimorbidity face ongoing challenges and are at risk of suboptimal visit quality. Health systems, payers should operationalize telehealth best practices and engage patients and caregivers in the way that telehealth is deployed, utilize interpreter services, make sure that they work to simplify technology and workflows, offer training and support to both patients and staff, and continuously monitor the quality of services to ensure access and equity in telehealth. Next slide. Thank you very much for your attention, and thank you to the organizers for inviting me.
Great, thank you, Marina, Barrett, and Lauren, and Mike. Various questions have come in. Maybe just to start, I can say we have just till the hour, so we're going to skip some very easy things like, you know, Mike wants everybody to know that his favorite vegetable is eggplant. But besides that, I could say one question that came in is a series of questions about the PAM and how, you know, how patient activation is operationalized and defined. There are a bunch of different complexities around this, and we actually tend not to use that tool. A lot of the items seem to be too complicated for linguistically for many of our participants, but it did seem to work for you, Barrett. So I don't know if you wanted to talk more about patient activation, or if anyone in the group wants to, but in particular, you know, people who get a perfect score in the PAM are supposed to be kicked out. And so how many people got top coded out because it doesn't function in that manner? So if you would. You're muted, Barrett.
Sorry. And thank you, and interesting perspectives. Actually, when we first launched the PAM, it was in a larger study, which this PAM COVID-19 is nested in. And I discussed all the complexities with Michael in the beginning of the study, because also there's a license problem and there's several different issues around the PAM. However, when we started the original study, which is about communicating patient-reported outcome measures in community health services, we did cognitive interviews within a group of patients with chronic disease and conditions, and with various age groups. And it went well. I think we have, as you say, the PAM, you have to delete cases where they have scored the same measure or the same category response. I think we have less than 5% doing that. Yeah.
Great. So in the chat, Mike has posted a link to the CHAI, which is what you can get without the same licensing complexity, and people should check out the CHAI. And there's a literature around patient activation, and it's kind of worth considering how that relates to this space, as Barrett pointed out. I'd like to move on to a different thing. Marina, a lot of health systems had to, you know, jack up this telemedicine stuff like really, really fast. And, you know, of course, no one would have allowed us to do this without the pandemic. You know, and yet it seemed to meet a very huge market need that's not going to really go away. And so looking into the future, I don't know how people are thinking, if you have comments about this, and in particular, how to continue to provide services that are not causing barriers by health literacy or by language. There's a specific question there as well, which is actually functionally speaking, what happens when you send someone a link if they have never used this before at this point? What is activated? What's embedded within that link is a specific question that came in. How does it work if they haven't downloaded anything before? I don't know if you're ready to
yes.
talk about this. Yeah.
Yeah, so the way that it works, this is version 2.0, if you will. If you send a link, right now, all a patient has to do is click on the link and they are connected. And then they can just, it's pretty simple, where they do have to know they may have to know how to unmute or show their video. But there's also a way for them to practice before the appointment, which helps a lot. And, you know, to your question, how do we continue to do telehealth? In the United States, it's really linked to reimbursement. So as long as reimbursement continues for telehealth, the way that it has been for the pandemic, health systems will need to be able to offer accessible services, if you will, and services that allow for access and don't alienate patients. But there are some things that we have to figure out in the United States. For example, some health systems where the academic or the clinical practice is on site where the hospital is, those practices miss out on facility fees from Medicare, even if telehealth is reimbursed on par. And so there are regulatory and financial issues that have to be figured out. And I think that the clinical workflow and workload will follow as long as it gets reimbursed.
I agree wholeheartedly. There's all kinds of complexities there in terms of it. In Massachusetts, for example, we have to confirm that the person you're talking to is physically in Massachusetts at that time.
Right. And we have that as well now in Pennsylvania. Before we didn't have this, but now we cannot, unless I have a New Jersey license, I cannot talk to a person, even an established patient of mine, if they're in New Jersey. But if they cross the bridge and are sitting probably in a parking lot somewhere, they can talk to me. These things don't make much sense. So we have to figure this out.
Right. You could talk to them, actually. You just can't bill.
I can't bill. That's exactly right.
So it's a bizarre scenario. Maybe to shift gears a little bit, another kind of thing, Mike, you have this longitudinal data about about COVID and health literacy, and a lot of what was presented was kind of a little more earlier on, and so maybe if you took the opportunity to think about kind of the trajectory of things, how things have evolved, and make comments about that. And one of the questions that came in also was about sources of news and specific things like that, which may be maybe a bidirectional phenomenon, which sources you choose and then what you have learned from them. But take it away.
Yeah, no. So yeah, we Lauren did present some of our initial trajectory analyses where you start to look over at least the first 8 to 10 months post outbreak, looking at perceived susceptibility. We do have data on media consumption, and it started off just looking at where were they accessing information, and then it got more granular to the point of what channels, so you can get really a sense of when they're starting to see a political divide, in terms of misinformation, what sources you're getting at. Stacey Bailey led those initiatives around that. So we do have data in our group to look at that a bit. I would say the one comment I would say that where things have evolved and where we're at right now, to no surprise, is we went into this looking at it more as a study of looking at healthcare access and chronic disease self-management. It really turned into a story of mental health. So where we're at right now is, even in our current wave of our survey, we're now asking and trying to assess post-traumatic stress symptoms. It's more around self-efficacy, anxiety, depression symptoms that we're starting to see really kind of populate at a high degree. We're looking at lifestyle factors that could be very adverse as a result of kind of changes in mental health. I think about nearly 40% of our sample is hitting the highest level on the audit C in terms of harmful drinking. Physical inactivity is quite prevalent as well. So I think we're starting to track those trends data. We have a study that should be an NIH project that should be funded once the budget gets cleared, that'll allow for a 5-year window post initiation of the pandemic to really get an understanding of how people are doing and who's still kind of who's fallen through the cracks, maybe in need of kind of support.
Great. Well, hopefully you're right. I mean, you're right. This is a mental health disaster across the whole world. Anxiety levels just gone up everywhere. But with that, we have to go to another session. And thank you very much. It's COVID's going to be here, so there's a lot of work to do. And I'll see people in the next session. Bye-bye.
Thank you.